welcome to the FlightBridgeED Podcast series. Hey everybody, Merry Christmas, Eric with you. Today we're going to do another case study. I think we've had really good success with the case study approach, and we're going to talk again about 12-lead interpretation, but we're going to look at a specific actual one lead out of the whole 12-lead, and we're going to talk about a new concept that's been kind of sweeping the world. We've seen multiple articles and research papers published on this, and I know talking to cardiologists that I've worked closely with on different projects, this is a fairly new concept, but they're using this in a diagnostic way to identify MIs in kind of new ways that we maybe in the past would have missed. So the name of this podcast is aVR, the Forgotten Lead. And so again, we're going to start with a case study. We're going to go through the case study, and then I'm going to talk about the actual literature, talking about the pathophysiology and what we're actually looking at, and then we'll kind of finish it off with how that case ended up. So our case study today, we have a 44-year-old male that was being flown to a larger level cath lab, was transported by EMS for chest pain. He arrived about 30 minutes after onset. He had severe crushing left-sided chest pain that radiated into his left arm. He did have a long history of hypertension, and he was a heavy smoker of about 3 packs a day. His current blood pressure was 136/90. His heart rate was 75. His respiratory rate was 18, and his SATs were 95%. They did start some treatment regimens on him. They started on O2 at 15 liters per minute. They gave him a sub-Q shot of Lovenox. They gave him some baby aspirin, 324 milligrams. They gave him low pressor, so this was back when we were actually giving low pressor for MIs to kind of reduce that heart rate down and that blood pressure down. I know now we're not doing that predominantly throughout the country. That's kind of a lost treatment modality, and we're treating the pain now. Remember from our previous podcast, we're treating the pain with fentanyl, with morphine, with our nitro drip, and that in turn reduces our blood pressure, reduces our heart rate. They did have him on a nitro drip at 20 mics per minute, and his pain was a 9 out of 10. When the flight crew got there, they identified that the patient was hemodynamically stable, and basically the 12 lead revealed no profound ST elevation, but it did show some new things that we're going to look at. So this is the basis of this whole podcast. Okay, his 12 lead at this point showed ST elevation of 3 millimeters in aVR and 1 millimeter in V1. The rest of the precordial leads, so V2, 3, 4, and 5, and then your lead 1, 2, AVL, and the inferior leads all had depression. So they had 2 to 4 millimeters of depression in all of the leads. So let me say this again. He had 3 millimeters of ST elevation in aVR, and he had 1 millimeter of elevation in V1, but all other leads had depression of 2 to 4 millimeters. Okay, so this comes back to what this means. Historically, when I first learned how to teach 12 leads and read 12 leads, we were taught that aVR was a lead that we didn't really worry about, that it was kind of up in the no man's land. It looked at basically that right atrium filling, the preload aspect of the heart. And so we really didn't use it diagnostically for anything. The one thing that we were taught to use it for was to make sure that our limb leads were correct, that if your white and your black were reversed, you would actually have an R wave in aVR. And we know that if we have good limb lead placement with our 12 lead cables, that we're going to have a downward deflection. We're not going to ever see an R wave. We're going to have that QS wave, and that is a physiologic finding. And that's all we looked at aVR for. And then as we progressed, we identified that aVR was also diagnostic to look at a wide complex tachycardia versus VTach. And a lot of times that was really difficult to identify one versus the other. And we know historically that we treat SVT with adenosine or maybe a calcium channel blocker, and we treat VTach with either lidocaine or amiodarone nowadays. And so we really didn't know how to treat either one because of that wide complex tachycardia of unknown etiology. And so aVR was a great prognostic indicator of how we would treat one or the other. And the way we did it was we did a 12 lead on the patient. Obviously, this patient would need to be stable enough to need medications. Obviously, we would, if he was unstable, we would go right to cardioversion. So this patient would need to be stable. We would do a 12 lead. And if AVR was down, so if we had that QS segment like it should be, that told you that it was diagnostic for SVT with an aberrancy. So it was SVT with an aberrant conduction causing that wide complex QRS segment. If it was up, if you had an R wave in AVR, then that was prognostic of or diagnostic of VTAC, and you would treat that accordingly. Back, 10 years ago, we would treat that probably with lidocaine, and now predominantly around the country and around the world, we would go straight to amiodarone. So those were the two ways that we looked at AVR, were just those two ways. Now, all the research is showing that AVR is a great indicator for left main occlusions or left main progressive disease process. There's an article that I'm going to refer to, and it actually titled Lead AVR, the Neglected Lead, or the Forgotten Lead, and it's out of the Journal of Association of Physicians of India. And this is just the newest research project that I've found that they focus strictly on AVR and the diagnostic qualities of AVR alone. And this was published in September of 2013, and it's volume 61. So you could Google that and you could read the article. I highly recommend it. There's a great abstract that kind of focuses on the whole paper, and then there's multiple 12 leads through this paper that you can look at, and you can see the different aspects of what AVR does. So what we need to look at now is we need to look at basically the different rules that they have found that really look at AVR from a different point of view. Historically, when we looked at AVR, like I've been saying, we looked at this and it was the forgotten lead. It was a lead that really, if you looked at a 12-lead approach, there was really only 11 leads that we looked at. And so there was a common belief that AVR had no clinical significance whatsoever. So let's talk about the different patterns that we're going to be looking at and how AVR can actually be diagnostic. Through the studies, what they've identified now, the AVR is basically what's called a STEMI equivalent. And so we know historically that we looked at our 12 lead systematically, and we had to have two contiguous leads with at least 1 millimeter of elevation. So now they're looking at AVR as a STEMI equivalent that requires emergent reperfusion of a patient, and again, it's indicative of left main artery disease or left anterior descending artery occlusion. So let's look at the predictive values of ST elevation with AVR. So these are the things that we're looking at, and it's really not that difficult. The first thing we're looking at is when you have ST elevation in AVR greater than or equal to 1 millimeter, this indicates proximal LAD occlusion or severe anterior descending artery occlusion. The second thing we can look at is ST elevation of AVR of greater than 1 millimeter predicts the need for CABG. It's very highly suggestive that this patient has a very high left main occlusion. We know any left main occlusions are very, very poor prognostic if it's not caught early, and those are the widowmakers. So they've identified, based on all the research, that ST elevation AVR greater than 1 millimeter is predictive of a patient with that progressive disease process that needs a CABG. Third, ST elevation AVR greater than 1 millimeter differentiates left main occlusion from a proximal LAD occlusion. The last thing, which I think is a huge aspect here, is the absence of ST elevation in AVR almost entirely excludes a significant left main occlusion. All right, so let me say that again. Absence of ST elevation in AVR almost entirely excludes significant left main coronary artery occlusion. So that's huge, guys. So what we need to do is we need to immediately look at a 12 lead. We need to identify if we have, elevation in two contiguous leads, the standard thing that we've always looked at. So if we go back to this patient presented with sudden crushing chest pain, 9 out of 10 that radiates into his left shoulder, but his 12 lead didn't show any classic ST elevation. So this patient historically, I know in all the area that I work in and around the country, pre-hospitally, this patient would not be a candidate for placement into a cath lab, right? Because he had ST elevation in just aVR and V1, and he had depression everywhere else. So aVR, again, historically, we never looked at as diagnostic, so that would have been forgotten. It probably wouldn't even been looked at. We wouldn't even have taken a second look at it. Once we identify we have a downward deflection, we have that QS segment, we know our limb leads are correct, we would probably have forgotten about that, and then we would have saw elevation in lead 1 and no elevation anywhere else that matches the contiguous leads protocol that we've always been taught. So this patient would have been forgotten, could have been transported to a facility that couldn't handle a cardiac patient, and very likely could have died from this disease process. So let's go back to his presentation. He had ST elevation of 3 millimeters in aVR and 1 millimeter in V1. So if we go back to the rule, if you have ST elevation in aVR, that is greater than elevation in V1. So you have to have elevation in aVR, elevation in V1. When you have aVR elevated higher than V1, this is highly suggestive of a left main obstruction. Okay, so let's go back to his 12 lead. His 12 lead, basically, he had 3 millimeters of elevation in aVR, and he had 1 millimeter of elevation in V1. He had ST segment depression in all of the leads. So lead 1 AVL, 2, 3 AVF, and the precordial leads V2, V3, V4, V5, and V6. The only 2 leads that he had elevation in were aVR and V1. And so when you have that in conjunction with each other, that's very highly suggestive, again, very diagnostic for a patient that has a left main occlusion that's pretty significant. Again, if we go through the different predictive values of ST elevation in aVR, we have ST elevation in aVR greater than 1 millimeter indicates proximal LAD occlusion or left main occlusion. Second, ST elevation in aVR greater than 1 millimeter is predictive of a need for CABG, so that's highly suggestive, highly diagnostic. ST elevation in aVR that's greater than V1 differentiates left main occlusion from a proximal LAD occlusion. So what they're saying there is if you have aVR that's elevated higher than V1, you have a very high left main occlusion. If it was reversed, if aVR was elevated and V1 was elevated, but V1 was elevated higher than aVR, they're saying that that is going to be an LAD occlusion. That occlusion is farther down the line, so it's not actually above that circumflex branch. If we remember the anatomy of the heart, we have that left main anterior descending artery that branches off into that left circumflex, left marginal artery. So if it's below that, then you're not going to have lateral involvement. The last thing, and I think one of the biggest aspects of this study, absence of ST elevation in aVR almost entirely excludes a significant left main occlusion. Okay? So let's go back to him and let's kind of find out what happened. When we look at this patient's diagnosis, when they got him to the cath lab and they did the catheterization, they looked at it. The left main, so above that circumflex branch, was actually open. The left anterior descending artery was completely occluded, 100%, and the left circumflex artery was 95% occluded. And the left marginal artery that branches off of that left circumflex artery was 80% occluded. The patient also started having ST elevation changes later on in the case in the inferior wall during the catheterization. So this patient was determined to be left main dominant as well. So not only was he left main dominant, but if we look at this from the big picture, we talked about this a few weeks ago, a patient that's left main dominant, that left circumflex artery essentially wraps around and feeds that lower part of the inferior wall, the posterior wall, and the right ventricle. So this patient had multiple problems. And if this physician wouldn't have been able to identify or know this recent new literature with aVR being diagnostic, I would argue that this patient could have possibly died from this MI. It would have been probably missed. I've spoke on this subject now a few times over the last 6 months, and I find it very fascinating. I'm always trying to learn new things and always trying to spread the word. You know, a lot of times we hear about these studies way late. You know, this study was obviously in 2013, but they had been doing it for the last few years. And I've talked to a few cardiologists, and you know they're aware of this and they're using this in their practice as well. But it takes a long time for this information to trickle down to EMS. That's the whole reason why I started FlightBridgeED, was to try to bring level 1 research information down to the rural areas, to people, practitioners, paramedics, nurses, everybody that deals with these patients on a day-to-day basis, so we can actually try to decrease mortality and use this great research that's being done around the world. This patient did very well. He obviously was 44, very young, and remember the whole basis of collateral circulation. A very young patient like that hasn't had time to form collateral circulation, so that's kind of another strike against him. If this wouldn't have been caught like it had, again, very highly likely that this patient may have died from this presentation. Again, review the article. The article is called Lead aVR, the Neglected Lead. It's out of the Journal of the Association of Physicians of India, September 2013, volume 61. It's an excellent article, very easy to read, great abstract. I highly recommend you look it over and apply these things to your clinical practice. That's all I have. I hope everybody has a great Christmas. We want to thank everybody. We just got back. We did 2 different classes. We did one in Brookings, Oregon about 3 weeks ago. Very, very successful. And we went up to last weekend and we did a class in Portland, Oregon. Got to see a lot of old friends. So I want to thank you, Mike Verkest, longtime friend. I love you. Michelle Croft, again, longtime friend. Love you too. And a lot of great people that I've known for a lot of years that made our trip out there very, very enjoyable. So look on our website on live events. We've got 6 different classes already scheduled from January all the way to November. We've got 2 in Colorado, 1 in the Los Angeles area. We have another one in Portland, and we have one in Kentucky. So check out the live events, and we will talk to you soon. Thank you. We want to thank you for following FlightBridgeED.